Thank you for that question. Yes, typically localized prostate cancer is a diagnosis diagnosed and treated by urologists. At Dana-Farber Cancer Institute, we have a very multidisciplinary approach to cancer, and the medical oncologists are involved in most prostate cancer patients' journey from the very beginning. So, over the course of my practice, I was seeing a lot of patients with localized high-risk prostate cancer, and I really understood the concept of applying therapies early to prevent relapse. Like affecting a cure, a higher cure rate, is a very high target, but very meaningful, and that's what I chose to focus on for these patients. I would say we were pushing against conventional wisdom to some extent. The field, for decades was doing surgery and sort of deal with the relapses later, or, you're too high risk, you're not a good surgical candidate, have hormones and radiation, and the hormone therapy with radiation for high-risk disease can be quite long. Now, on average, we're giving it for about 2 years. So we did this series of small phase 2 trials starting in 2009 with 50 to 120 patients, and kept exploring various hypotheses around androgen deprivation therapy intensification using the ARPs, the androgen receptor pathway inhibitors. And each trial looked, more and more positive. And as we built the data up and built a database of patients in Boston, we could then retrospectively look and see that the patients who were having a major pathologic response weren't relapsing. They were freedom from PSA failure. Eventually, we were able to show that freedom from metastasis. So those data over that 14-year period really provided the hypothesis and the preclinical, the pre-phase 3 work for PROTEUS, and I would say gave then Janssen, now J&J, the courage to invest in a large phase 3 trial. What's remarkable is PROTEUS is the first phase 3 trial in localized high-risk prostate cancer in 13 years. There was a 13-year interval between the PUNCH trial, which was a cooperative group trial looking at androgen deprivation therapy and chemotherapy, and the start of PROTEUS. That's sad for a group of patients who have such a high relapse rate and unmet need. Yeah, so there were 2,109 patients on the trial, and at Dana-Farber we had 77 patients on the trial. So the trial was blinded, so we didn't know which patients were receiving apalutamide and which were receiving placebo. So there really was no point during the trial where we had any indication what was going on. The statistical plan had 3 analyses, which we ended up having to go all the way to the 3rd and final analysis. So we literally didn't know that it was a positive trial until the results were unblinded after the final analysis, which was amazingly just in February of this year. So we've prepared this presentation for ASCO Plenary, the New England Journal paper, in literally weeks. So it's exciting. What it means to me is that it's good for patients. It's affecting better outcomes in our most advanced stage, metastatic castration-resistant, and now up to those patients with localized disease, but at high risk to relapse. The eligibility criteria in PROTEUS were more than just simple high-risk disease. Like if you had a Gleason 8 tumor and 2 core biopsies, you couldn't get onto PROTEUS. You needed 6 core biopsies, So these are very high-risk patients. 12% had evidence of lymph node spread in the pelvis at entry. We allowed that. So I'm excited that, a drug, an androgen pathway receptor inhibitor like apalutamide, can, perhaps prevent 20% of people from, relapsing and having the morbidity of subsequent therapy and living their life. I can tell you as a provider, seeing these patients in clinic, the PROTEUS patients, every 3 months they came in, they get a PSA. Every PSA that was 0, it was like you gave the patient $1 million. They're very focused on their PSA. And having a therapy like this that extends remission for so long, there was almost a 3-year difference in time to needing a next therapy for the patients who needed a next therapy. This is a very limited, a 1-year duration of therapy. I think it was 82% of patients quickly recovered their testosterone. The median time to recovery was in the 7 to 8 month range. And then 90% had testosterones over 100, suggesting that they were in the recovery phase. So that was good news for these patients. Yeah, well, I think that the PROTEUS is just the beginning. So the immediate story is that this will become a new standard of care option for patients who have localized high-risk disease, and they can weigh with their physicians the possible side effects of 3 components of therapy, right? Androgen deprivation, surgery, radiation, and choose the path that's right for them. But with the extensive biomarker work that we're going to do, hopefully the next set of trials will rationally design therapies to add to androgen deprivation therapy in the appropriate patients to affect an even higher cure rate. And why PROTEUS is paradigm changing is that with the power of 2,100 patients, we should be able to prove that a major pathologic response correlates with MFS. And I can envision a time when we could do therapy development more quickly. We had to PROTEUS started in 2019. This is 2026. That's 7 years, and maybe even add some time on for protocol development. So that's a long time to wait to change therapy. And, we only were able to do it in 7 years because of the change of standard of care of adding PSMA PET to both stage initially and stage at relapse. So hopefully looking back in time, PROTEUS will have really changed the field on all those aspects. Rational development of new therapies, quicker development of new therapies, and we'll get to a point where a patient can come in and the doctor will do the testing and recommend certain treatments based on clinical trials that will make the cure rate for these patients 98%.